Hello, my name is Ed Behrens, and I am the Chief of Rheumatology here at the Children's Hospital of Philadelphia. And I also co-direct the immune dysregulation program, where I see patients that have a number of different genetic and non-genetic disorders where the immune system tends to misbehave. And my research is in trying to understand the different causes for these kinds of immune dysregulation and what are the best ways to then diagnose and treat if we can understand the cause in a more detailed fashion. I've been asked to speak with everyone today about the relationship between type 1 interferonopathies and various rheumatologic and autoimmune problems that patients with type 1 interferonopathies have. And so we'll go over it's a sort of hefty subject to try and cover in a short period of time, but we'll try and hit the highlights and go over what I think are the most kind of important take-home messages for this arena. It's hard to have a discussion about the autoimmune or rheumatologic presentations of type 1 interferonopathies without really understanding what exactly it is that type 1 interferons are and how they work in the immune system in the first place. So we're going to start with that. Type 1 interferons are a class of inflammatory molecules that is made by the immune system in response to a number of different kinds of challenges with different pathogens, typically viruses. So it is a way for the immune system, when it senses the presence of a virus, to then tell all the other cells in the body that, hey, there's a bad guy here. We've got to go after it. We've got to do something to limit the spread of this virus. And so, in that fashion, type 1 interferons are really important in protecting us from all sorts of viruses. And in fact, the COVID virus has gotten a ton of attention with respect to its connection and type 1 interferon biology. So, as a sort of real world relevant example in the current world today, type 1 interferons have been shown to be important in fighting COVID virus effectively. And part of that is having exactly the right amount of type 1 interferons. So not too little, but also not too much, because sort of being off in either direction can make it a problem for patients to fight off the virus correctly. Where patients with type 1 interferonopathies like Aicardi-Goutières can get into trouble is because they may make too much type 1 interferon. And as a result, the body's natural protective processes get shifted into overdrive. And as a result of that, patients can get autoimmune problems because the immune system goes from being protective against viruses to being damaged against our own organs. Because virtually every organ and every cell type in the body expresses a receptor for type 1 interferon, the types of complications that can be seen in conditions where type 1 interferons are elevated can reach almost any organ. And I think we're still really learning what the true spectrum of problems can be for patients with type 1 interferonopathies, which makes it a difficult topic to cover in a brief period of time, because there are actually, in truth, a lot of different complications. So as I said, we'll try and hit the highlights. We've actually known now for a number of decades a connection between elevated type 1 interferons and autoimmunity. And the classic example for that is actually in a disease called systemic lupus erythematosus, or for short, just lupus, which is a disease that, again, can affect almost any organ. And we've known now for a number of years that for patients with lupus, it's actually related in part to an overexuberant type 1 interferon response. And so the idea that you could have organ autoimmunity as a result of elevated type 1 interferon is not necessarily a new concept. What we are now beginning to recognize is the connection between patients with genetic causes that lead to specific type 1 interferonopathies, specific problems in the type 1 interferon cascade in biology, and its connection to auto. While there's certainly a large focus on the brain and the nervous system, various genetic type 1 interferon diseases have been noted to affect other organs. The perhaps easiest example to understand is that there are, in fact, genetic mutations of the type 1 interferons that actually can lead to a lupus-like syndrome. In particular, mutations in a gene called TREX1 can lead to a familial lupus-like syndrome, often affecting the skin, and can often be in particular triggered by exposure to cold. And so we call it Chilblain's lupus, as one example of how a type 1 interferonopathy gene can result in autoimmunity. As we discover more and more genes, we discover more and more syndromes, and we get a better sense of the spectrum of this problem. There are mutations in other genes that cause other syndromes, in particular a syndrome called SAVI, which causes inflammation of the blood vessels and inflammation of the lungs. That can be a problem for patients with mutations in something called the STING gene, that, again, for reasons that we haven't totally quite worked out, but are clearly present in patients with this mutation, causes inflammation in those organs and problems. Can also affect simply having fevers for those patients as well. And then by extension, for patients with mutations in other type 1 interferonopathies, including AGS and other syndromes, patients have been reported to have autoimmune problems in the liver. Patients have been reported to have autoimmune problems in joints and other organs. And so there ends up being a wide spectrum of organs that can be involved by autoimmunity in these conditions. I think the world still has a lot more to learn about what that spectrum is and why it affects some patients and not others. And some hypotheses could be the particular mutation or gene involved. Some hypotheses could be the environmental exposures that any one individual patient is exposed to. And other hypotheses include other genetic interactions with the type 1 interferonopathy genes that alter the way these things present in other patients. And there's still a lot more work that needs to be done in sorting out which of those possibilities is correct. And it could be that all of them have something to contribute. Having said that, knowing that there's a connection between elevated levels of type 1 interferon and the development of autoimmunity, the development of problems where the immune system attacks one's own body, has made targeting type 1 interferon biology an attractive option for autoimmunity in general, and thinking about that in the type 1 interferonopathies in specific. We have a couple of ways to do that in the current era. The first of which is to use a class of medicines called JAK inhibitors. JAK, J-A-K, is a molecule that the type 1 interferon receptor requires to communicate the fact that it is sensing type 1 interferon elevation in the bloodstream. And so if you silence the molecule JAK, you don't necessarily change the amount of type 1 interferon present, but what you do is you make that elevation essentially invisible to the cells that are trying to sense it. And as a result, you can quiet down the inflammation that is driven by type 1 interferons. There are a number of choices for JAK inhibitors. We don't really have time to get into all the details of how each one is slightly different from another, but there are a number of choices of JAK inhibitors that can be used. And that is one way of lowering the interferon response in patients that have too much type 1 interferon. And I think while this still requires further study to understand how good it is at taking care of these autoimmune problems, we think that this might be one way to approach lowering the autoimmunity associated with elevated type 1 interferon. A relatively new option that we now have available for lupus patients is another drug that is an antibody that can basically bind to type 1 interferons and sort of soak them up like a sponge. So unlike the JAK inhibitors, this doesn't affect the sensing of type 1 interferon, but rather gets rid of the excess type 1 interferon itself. Now, we don't have a lot of data for this drug in the space of type 1 interferonopathies proper. It's only really been studied and approved for lupus patients. But another interesting option and thought that should perhaps be studied in the type 1 interferonopathy domain, but is another FDA-approved medication that targets this pathway. So, as I say, each of these things come with different pros and cons that we don't really have quite enough time to get into. But the major complication of blocking type 1 interferon, not surprisingly, is you're taking away an important molecule that we've just said the body needs to fight off viral infections. So one of the main things we worry about in patients that we're treating with these drugs is monitoring for infections, monitoring the immune system to make sure that we're not overdoing it with immunosuppression so that patients can remain safe. And while there are not sort of standardized national, international guidelines for how to do this, each center kind of comes up with its own program. In general, we monitor the amount of different cell types in the blood from the immune system. And we monitor the amount of protective antibodies that patients have to make sure that they are still making protective antibodies against infections. And use that to help us guide the need for using various prophylactic antibiotics to protect patients from getting infections in the first place, and to understand how worried we should be about whether the dose of immunosuppressive medicines that we're using is too much or potentially too little. Without getting the specifics, I think it's reasonable to say that patients that are on these drugs should be monitored with some frequency to make sure that their immune systems are still able to have a protective response, so that patients are not going to get in trouble with infections, but still have enough dialing back of the type 1 interferon system to try and treat the autoimmunity inflammation that the type 1 interferonopathy is generating. So, as I've said, this is a complex space. There's still a lot more to learn, both in terms of what kinds of organs can be involved by autoimmunity, why the type 1 interferons in the first place are causing that autoimmunity, and what are the best strategies for walking that tightrope between trying to return those type 1 interferons to a more normal level to reduce autoimmunity, but leaving back enough type 1 interferon to protect patients from having trouble with infections. And so these will be the challenges that we will all be trying to address in the upcoming years to optimize the way in which we treat these patients. And I think that with further study and effort, we'll be continuing to be able to do a better and better job at coming up with strategies that walk that tightrope in the most appropriate way. And so with that, we'll conclude this presentation. Thanks for your attention.